Up Close is presented by Tennova Healthcare, with 6 hospitals and more than 1,000 dedicated physicians. For more information, tennova.com.
Thanks for joining us for Up Close. I'm Stephanie Aldrich. This week we tackle a health topic that's not always easy to talk about: urology, the health of our body's personal and private functions. Maybe over the years you've become afraid to sneeze with even just a slightly full bladder for fear of embarrassment. Or you have a family history of prostate cancer, a leading cancer killer for men. Dr. Katherine Cameron talked to us about the warning signs and the latest treatments and surgical tools she has to help bring back quality of life for patients. We also talked to her about a special distinction that she has as a female urologist. Dr. Cameron, can you just tell me a little bit about your background and how you first got interested in the field of urology in the first place?
Well, I loved using my hands, and so I had always thought I wanted to do internal medicine or pediatrics, and where you get a lot of patient interaction. But I fell in love with surgery, and I loved using my hands. I loved being able to fix things, and so urology offered a sort of nice blend where you got to operate, you got to fix things, but there is some patient care where we follow patients over time. So it's kind of the perfect blend between medicine and surgery.
And you have a special distinction locally as a female urologist. Could you tell me more about that?
Sure, I'm the only operative female urologist in Knoxville, and it's a nice niche, obviously, for me as a professional, but for patients more than anything. It offers them another opportunity, another resource. Obviously, a lot of females prefer to see a female. I've had patients that have said they've been waiting for years to have a female urologist come into town in order to take care of their urologic condition. So it just offers them that additional resource that they could have.
And that's what I was going to ask you too. I mean, you certainly have male patients, but you feel like it really has opened the door for female patients as well, just with their comfort level to a certain degree?
Yeah, I do. I think they feel more comfortable being able to confide in a female. They feel comfortable kind of telling a female maybe more intimate things than they would feel comfortable telling a male physician. They feel like a female can empathize a little bit more. We've got the same parts.
Yeah.
And so I do. I think females are just naturally drawn to seeing other females.
But why do you think it is important for more women to go into this field?
There's obviously more and more females seeking care for their urologic issues. And so they do feel more comfortable with other female providers. And so that's important. And the Society of Women Urology has been great for me as a professional because it affords me a support structure, a networking structure, resources where we can get together and meet as providers and exchange ideas and techniques and treatment options and things like that.
Well, let's talk about fixing things.
Yes.
One of the things that women will come to you about is incontinence. Tell me more about that. Have you seen a shift also in women wanting to address this instead of just being like maybe, past generations were like, oh, I'm just getting older, or this is just something I have to deal with post-childbirth, or what have you noticed?
Definitely. There's definitely a trend, a generational shift towards seeking care for that. That is kind of the classic problem that people are seeking. And I think some of it's education, knowing that there is something out there that can be done. But previously, there was either nothing that could be done for it, or it was very large invasive surgeries. The recovery time was prolonged. Most of the women were the homemakers, the caregivers of the children, and they didn't have the ability to take the time off for recovery for such a surgery. So there is definitely a shift. We've gone from those big invasive surgeries to nice little small, minimally invasive outpatient surgery.
What would be some of the signs of maybe I just need to, kind of deal with it or give it some more time? And at what point should someone maybe see a doctor about that? What are some things that you've seen with your patients?
Well, if we're talking about incontinence, of course, the one thing that I tell my patients is nobody ever died of peeing on themselves. So, we're talking quality of life. So the first question you need to ask yourself is this affecting my quality of life enough that I want to go talk to somebody about it? And you don't even have to want surgery, but you just need to know the options, because there's certainly non-surgical options that we can do. Sometimes it's not even surgery that's indicated. It would be even maybe medicine that would be indicated. So that's probably the main question to ask yourself is this affecting my quality of life? If it's in a rare occurrence, you probably don't need to do anything other than our Kegel exercises. But if it's bothering you, come in, be seen, be checked out. Probably the one sign that I would say that you definitely need to be checked out, if you had blood in urine, and that would be a different issue, but that's the one thing that is not normal, and I would certainly see your doctor for that.
So what are some of the other non-surgical treatments for incontinence?
Well, the mainstay is Kegel exercises, and then as our society has become bigger, weight loss is the biggest thing. That is one of the biggest contributors to incontinence and even pelvic floor dysfunction. And so those are the two mainstay non-surgical options. There are some devices that we can fit you for, pessaries, but the surgeries have gotten so minimally invasive that most patients are candidates for surgery.
Tell me more about the surgery. Can you walk me through it a little bit as far as what do you do exactly?
So the surgery for stress urinary incontinence, which is incontinence associated with increases in abdominal pressure. So when you cough or sneeze or laugh. So we make a tiny little 1.5 centimeter incision underneath the urethra. We make a little pocket or space for the little sling. It's like a little hammock, and it hooks in behind the pelvic bone. And that's pretty much it. That's the surgery kind of in a nutshell. Then we sew up the incision. We do look in the bladder, so there's a little cystoscopy that we do at the end of the procedure. Of course, the patients are asleep. That's always a question. But it takes about 15 to 20 minutes to do.
And do you have some special tools that you like to use in that? Are you using the robotic surgery for that?
Not for the incontinence, but for the pelvic floor prolapse I do. And so there are a lot of different slings. And when I refer to sling, I'm talking about a mid-urethral sling. People use sling very loosely. But I'm talking for a urethral sling for incontinence. And there's a bunch of different ones that I use, or that are able to be used. I have two that I use. But I do use the robot for prolapse repairs.
Tell me more about that.
So what we've done is we've taken this new technology and adapted it to older surgeries. So the main surgery for prolapse that I do is called a sacrocolpopexy, but that's basically where we just lift the pelvic floor organs, the bladder and the rectum, and put it back where they were supposed to be, where they've kind of fallen down.
And what can cause things to not be where they're supposed to be anymore?
So of course age is related, childbirth, having had babies, being overweight, smoking is a risk factor for that, and actually having had your uterus out, so a hysterectomy. Those are all risk factors for having prolapse. And the symptoms are where you may feel something hanging down and out the vagina. People say, I feel like I'm sitting on a ball. They can see something. I've actually had patients come that they actually don't have too many problems other than they've seen it and they're concerned they may have a tumor. And it's actually just, the bladder dropping down. And the other misconception too is that it's actually the bladder hanging out, but it's like a hernia. And so it's the bladder just pushing the vaginal wall out. So it's actually just the vaginal wall they're actually seeing. They're not seeing their bladder.
What kind of recovery are you looking at for a prolapse surgery as well as incontinence? And I know it depends probably how much you're having to do and repair. I understand there's some variables there.
So for an incontinence surgery, the main thing for that is just the limitations. Most people feel good 3 to 5 days after that surgery, and they have to remind themselves their limitations. Whereas prolapse surgery, it is a bigger surgery, so I do have them limit driving a little bit longer, but everybody's individual. And so the nice thing about the robotic surgery, there usually is less pain medicine use because there's not as much pain, and so therefore they can get back to normal activities sooner. But I would say a 6-week window for the prolapse repair surgery. And then you still have a 6-week limitation on the incontinence surgery, but you're gonna feel much better after a week or two.
And I guess you're talking about just, limitations on your exercising, lifting,
Yes,
things like that, just
exactly.
your overall activity level.
Exactly.
Even if you feel like you're ready to go out and conquer the world again, right?
Oh, and I have had to talk to patients about it. I've caught them out doing yard work and said, get back inside, you're not supposed to be doing that. Yes.
Obviously, anytime you fix something, you're going to feel better, but do you have any examples of patients where this just, maybe they dealt with this for such a long time with incontinence and that just really changed their life?
Just about everybody that deals with incontinence, sure. I mean, where you go from, I can't go running, I can't jump on the trampoline with the kids, I go to the mall and I can't make it to the bathroom, and all of a sudden they're not having to buy pads, depends. They can go run, they can go jump, they can go play with their kids outside. I mean, the stories for the incontinence surgery, and then for prolapse the same. I mean, there's a lot of people that had terrible pain, they were bothered by it, they couldn't have intercourse because it hurt, and so it's an everyday quality of life issue that all of a sudden has changed.
These can be signs of more serious issues, but in and of itself, it's more of a quality of life issue. Do you think that's why people maybe sometimes put off doing something and think maybe I should just, oh, it'll get better on its own? Does this ever get better on its own?
Well, prolapse does not. I mean, once it's dropped, it's probably going to stay there. Certainly Kegel exercises can make it better. You can get better tone in your pelvic floor, so it's not as bothersome. But once it's dropped, it's going to stay there. That's an anatomic issue that has fallen and gotten weak. Incontinence, yes, incontinence can get better. With Kegel exercises and weight loss, that is one of the true examples of a little bit goes a long way. If you lose 10% of your body weight, that translates to a 50% reduction in your incontinent episodes. So now when you get to severe incontinence, while it may get better, it may not get to the point that you want it to be. So it also depends on what your expectations are.
What's the problem with the caffeine? It's just the stimulant part of it?
It's a notorious bladder irritant, and it irritates the bladder. It can give you bladder pressure. It can make you have the urgency. It can even give you spasms to where you do leak. And it's just a well-known, well-documented urinary irritant. It's also a diuretic, so it can make you go often.
Right.
And so that's kind of the bad part of caffeine to the bladder.
People are probably more caffeinated in their day than they realize, right?
Yes, and it's impressive when you ask them, do you drink any caffeine? No. Well, they start thinking about it, and then you go through. You do coffee, tea. If you drink tea out, it's almost never decaffeinated. If you make it at home, you can get decaf. Sodas, the dark sodas, or the yellow sodas, and then chocolate. Chocolate has a lot of caffeine, so our chocoholics that eat it all the time, certainly it's not healthy to eat that much chocolate.
So 2 cups of coffee, some tea at lunch, and a little chocolate in the afternoon, and you might be having contributing to some issues at any rate.
Sure.
Okay. One of the other things people come to you pretty often for is kidney stones. Can you tell me some of the warning signs of that you might be dealing with that versus some other kind of pain or some other kind of issue?
Sure. Well, kidney stone pain is pretty classic in its classic form. You get acute onset of pain. You cannot get comfortable. It's typically one-sided, and in the back, our kidneys live up underneath our rib cage. It can radiate around down to our groins, and you can see blood in the urine. You can have the bladder pressure and frequency if it gets down, the stone gets down near the bladder. But the back pain is the sort of classic kidney stone pain.
And then what do you do if someone is feeling that? What is the next step that you do if they come to see you for that?
The classic and standard of care imaging study would be a CAT scan. You do a CAT scan. You don't have to have contrast for it. In fact, we don't do contrast with stones.
What would be usually the advice from then if you do the scan and then you notice it?
The treatment options for stones depend on size and location of the stone. If it's a small stone, so generally under 5 millimeters, then it is a passable stone. So then you see, how is the patient controlled? Are they having fevers? That would actually be one of our urologic emergencies if you have an obstructing stone with fever. And so you can give a trial of passage if they're doing well and they don't want surgery. If it's a large stone, it's not going to be passed, and depending on the location, you can either go get it with a scope, or you can do the lithotripsy, which is where we use ultrasound waves that travel through their body, kind of acts like a jackhammer, and bust the stone up, and then they pass the dust.
Are there some lifestyle factors that can contribute to that as well?
Stones are generally multifactorial, meaning caused by multiple different factors. So genes play a role, so family history of stones, moms, dads, brothers, sisters have had stones before. Diet, we talked about being dehydrated with caffeine. We don't like a lot of sodas when you have stones. One of the biggest things is being dehydrated, and we just don't drink enough water. Being in the South, especially in the summertime, it's kind of the stone season. People will get out.
Really? You actually see it more then?
Sure, in the summer, yeah, people they sweat, so they have insensible losses. They don't even realize that they're as dehydrated as they are, and they don't drink enough to compensate for it. So they get concentrated, and that's when the crystals precipitate out a solution and form your stone. And also, we kind of joke about being in the stone belt because in the South we love our sweet tea. And tea is a big contributor because it has a lot of oxalate. The most common stone is a calcium oxalate stone. And tea, well, it's not the caffeine in the tea, but it's actually the oxalate in the tea.
Probably one of the most common things people come to you for would be just urinary tract infections, and or if those things are recurring and they want to come see you. What would be some of the signs that someone is dealing with a UTI?
Well, the classic symptoms of a UTI: burning when you urinate, frequent urination increase from what you normally do, urgency to go, the constant sensation that you have to go to the bathroom. And those are kind of the classic. Blood in the urine, you can see blood in the urine with an infection if it's really bad. And so those are the classic symptoms.
Is that really a sign of a much bigger problem?
Usually urinary tract infections, you can eradicate the infection and then move along. If you have 3 or more infections in a year, then that's when generally they get sent to the urologist for us to investigate, is there anything else going on? And we can assess their anatomy, their lifestyle choices, are there other things that are contributing to them having infections? And that's where cranberry juice can come in, or cranberry supplements. Sometimes people can't get enough juice or they don't like the juice, so they do have cranberry pills, and they are equivalent. You get it a little bit more concentrated in a tablet or the capsules, and so it can be a little bit easier, and there's not as much calories. It's sometimes hard to find that low-calorie cranberry juice.
Yes.
And it has to be the real cranberry juice. It can't be the cran apple, cran grape, good-tasting stuff.
Well, the urologist is saying cranberry juice, the pure stuff, can help you with those.
It does work.
You do see a lot of male patients as well. And enlarged prostate and prostate cancer, definitely on your list of things that you have to screen and treat. Really, how worried should men be about this?
The AUA has just updated their new guidelines on screening for prostate cancer. And so the age range that we're most concerned about are those between 55 and 69. And that's where you should be getting your screenings, or at least talk to your provider about screenings. African American men are at increased risk for developing more serious, life-threatening prostate cancers, and those with a family history. So those are the main risk factors. If you have had a family history, then you may want to start your screenings earlier, and that's in that 40 to 55 range, where you may start screenings earlier, especially if your family member was diagnosed before they were 55.
So just like women need to be very aware with the statistic with breast cancer, this really needs to just be a part of a regular health check for men in that age group, right?
It is. And the screening is a PSA, so we've heard about the blood test as of late. So the PSA is a blood test. It's only produced by the prostate, and it screens for prostate cancer as well as the digital rectal exam. So the famous finger wave that men dread, but those are the way that we screen for prostate cancer.
You know, I guess the enlarged prostate would indicate maybe there is prostate cancer, but are there any other signs that men should be aware of before they start already assuming, oh, I wonder, don't want to think the worst?
Well, we hope to catch it before there are symptoms. I mean, a lot of times when we screen for prostate cancer with a PSA, we can catch it before they are having symptoms. But some of the symptoms are difficulty urinating, having to stand and wait for a long time. When you start your urine stream, it starts and stops on you throughout. Of course, blood in the urine can be, urgency to go, painful ejaculation. Those are all different signs and possible signs of prostate cancer.
And isn't, I guess, prostate cancer in and of itself, because initially there aren't a lot of symptoms, are there?
No.
And so that's why it needs to be caught early, I imagine.
It can sneak up on you, especially if you're not getting screenings. And so I strongly recommend, I've seen prostate cancers that have not been screened and have progressed because they are fairly silent. And so when they do present with symptoms or more farther along in the process and may not be curable. So getting screenings, we use the PSA, we use the rectal exam to decide if we're going to do a biopsy, to check for prostate cancer. We take into consideration the patient's health and other risk factors to decide. And even if you get diagnosed with it, you don't necessarily have to have treatment. We can do watchful waiting, so depending on it. So just because you get diagnosed doesn't mean you have to look at some of these life-changing treatment options, but of course then we kind of are armed with more information of what we can do and what we can offer them.
And that's what I was going to ask as well. I mean, while it can not present a lot of symptoms initially, and hopefully you just do the screening and stay on top of your health, because this is also something that's very treatable.
Yes, it is. And prostate cancer generally, just on average, is slow growing, but there are more aggressive cancers that are not slow growing. So it's important for the public to understand that that when you get screened and if you're diagnosed for it, your neighbor who may have had prostate cancer, it may be a completely different prostate cancer than what you've been diagnosed with. And so there are support groups for prostate cancer, but it is definitely a treatable disease and it doesn't require surgery. If you don't want surgery, we can do radiation, we can freeze the prostate, we can do seed implants. There's a lot of different options that we have for treating prostate cancer, but yes, it is very treatable.
What, in your opinion, are some of the better advances for treating prostate cancer today? What are you seeing that you are encouraged by?
Well, we have better radiation therapies now, and that is important. And even at Tennova, we're getting the IMRT, and so that is one benefit. We have the robot that we can use for prostate cancer. I actually don't do the robot surgery for prostate cancer, but we have several of our partners that do, and that has helped with post-operative recovery, the blood loss. The two biggest side effects of prostate cancer surgery is urinary incontinence and erectile dysfunction. And again, with the robot,
those things alone make people hesitant to want to move forward.
Exactly, which is very understandable. But with the robot, you again have your 10 times the magnification and your 3D. The nerves that stimulate erections run on the outside of the prostate. That's why they're affected when you do prostate surgery. But you can actually see those neurovascular bundles and peel them off, so you can do nerve-sparing surgery a lot more easily. So certainly there's some advances there for even the older surgeries that you can get. You can actually do a better connection. The prostate makes up part of the P channel, if you will, and it is bridges between the bladder and the P channel that men pee through. And so when you take that out, you have to re-sew that back together, and so you can see that connection a lot better with the robotic surgery. So that has helped.
It sounds like you're really encouraged with there just being a lot more choices out there now.
Yes.
For treating it, right?
Exactly. And even just in the past 3 years, we've seen an explosion and even advanced prostate cancer treatment options, which are amazing. So before, we may have had just very few options for patients that when prostate cancer occurs, and so there's even more options there. So I think we're just on this cusp of a lot of new technologies and a lot of new medications to treat prostate cancer, which is encouraging.
Are there also ways that you can really prevent prostate cancer, or just if you're in a risk group, you're in a risk group? Are there things that you can do?
There are some dietary modifications again, and of course living healthy and eating healthy. Tomato-based products are actually good for helping prevent prostate cancer.
Really?
Those are the lycopenes that are in the tomato-based products. Selenium is thought to potentially help. So there are we actually have some nutritional supplements that we even offer in our office that we offer for men that are at high risk. Being overweight is a risk factor. That's another risk factor. They did a study on several of the very common cancers, and obesity in and of itself, you are at more risk for developing several cancers, and prostate cancer was one of them. So again, eating right, staying healthy, can certainly help prevent it. But there is just some factors that there's nothing. It's just like cancer. Some are out of your control, except for our smoking. That's certainly a risk factor that we can control. But other than that, the family history and obviously being African American, those are just, you're at increased risk for it. So you just need to get your screenings.
Do you think there's a more of an awareness now with nutritional approach? I mean, of course, sometimes there is a need for medicines. They can do good work. They can help people, but is there more of a focus now today? Are we learning more about nutritional approaches, like you had mentioned with the tomato-based products and things like that?
Well, I think as with everything in medicine, we learn more as we research and study more. And of course, I think that the nutritional supplement has sort of exploded that whole industry, if you will. And there's some good to that. You have to be careful about some of the supplements because... And
you have to be careful for not doctoring yourself.
Well, that's true. Yeah. Definitely. That could be a problem. But a lot of those nutritional supplements are not regulated. No nutritional supplement is regulated by the FDA. And so they did a recent study. They did a study when I was a medical student, and they did a recent one that basically showed very similar findings, that half the time there's stuff in there that they don't tell you about, and there's not the stuff that they say is in there. And that's because nobody has to regulate the product. So we use a company that actually has a third party. It's not, of course, the FDA, but it is a third party that regulates their products. So we feel comfortable saying we know what's in this product. And so I think that, and then of course with the internet, and there's the education, and people are armed with more information. So I think that there is certainly a shift towards trying to see what else people can do nutritionally to help prevent and decrease their chances of developing prostate cancer.
Sure.
Or
But
other
always
cancers.
tell your doctor too, because just because something is natural or a supplement doesn't mean it wouldn't possibly interact with something else, right? You got to be upfront with your doctor.
Definitely, and I have patients that will list their prescribed medications, but they don't list their over-the-counter medications, and that includes a baby aspirin, fish oil, vitamin E. All of those 3 things are blood thinners, and so for a surgeon especially, it's important to know. So you definitely want to list both your prescribed medicines as well as your over-the-counter medications that you take.
Well, Dr. Cameron, thank you so much. You have to cover a lot of ground, from the basic urinary tract infection to even possibly treating someone more seriously with prostate cancer. You have a lot of ground to cover in a day, and thanks for sharing some of these technologies and your tips with us.
Thank you very much for having me.
The chances of a man developing prostate cancer in his lifetime is 1 in 6. A reason why it's important to get regular examinations, especially starting at age 40 if there's a family history. African American men are also at a higher risk. Early detection and regular exams are key to treatment, leading to the increased survival rates. We hope you'll join us again next week for another edition of Up Close. I'm Stephanie Aldrich.
Up Close is presented by Tennova Healthcare, with 6 hospitals and more than 1,000 dedicated physicians. For more information, tennova.com.